Hi class, this is Dr. Shahada, and in this video I'll briefly be going over Chapter 6 on individual rights in healthcare and public health. So a little overview of what we'll be covering. We'll be going over the meaning and the importance of the no duty to treat principle. We'll also be covering generally how the U.S. approach to health rights differs from that found in other high-income countries. And we'll also be going over the types and limitations of individual legal rights associated with healthcare, as well as the balancing approach taken when weighing individual rights against the public's health. All right. Now, before I really delve into the topic of no duty to treat principle, I first wanted to briefly just touch on the human right of health. So the human right to health really means that everyone has the right to the highest attainable standard of physical and mental health. So this includes access to all medical services, sanitation, adequate food, decent housing, healthy working conditions, and a clean environment. Now, the human right to health, when we use that concept, it should guarantee a system of health protection for all, which means everyone has the right to the health care they need, to living conditions that enable us to be healthy, as well as adequate food, housing, and a healthy environment. Healthcare must be provided as a public good for all, financed publicly and equitably. The human right to healthcare means that hospitals, clinics, medicine, doctor services are accessible, available, acceptable, and of good quality for everyone on an equitable basis, where and when needed. So the design of a healthcare system must be guided by the following key human rights in order for you to really have a true human right to health. You really do need universal access. So, which means access to healthcare where everybody is guaranteed universal access to healthcare services on an equitable basis. This means that healthcare must be affordable and comprehensive for everyone. It needs to be available. Adequate healthcare infrastructure. We're talking about the hospitals, community health facilities, trained healthcare professionals need to be available. Goods like drugs and equipment need to be available. Services such as primary care, mental health care must be available in all geographical areas and to all communities. Accessibility and dignity. So healthcare institutions and providers must respect dignity, provide culturally appropriate care, be responsive to needs based on gender, age, culture, language, and different ways of life and abilities. And there really needs to be a medically appropriate level of quality. So you need to have good quality that's guided by quality standards and control mechanisms. And healthcare needs to be provided in a timely, safe, and patient-centered manner. So this description I gave to you is really when we're talking about this true human right to health, what it entails. All right. In the beginning of this chapter, there were these real-life scenarios that were presented to you. And they really touch on the ways in which the law creates, protects, and restricts individual rights in the context of healthcare and public health. So we're deeply impacted by law on a daily basis. And this is also true when we're navigating the healthcare system. And, when regarding law in relation to healthcare, there's been many decades of where legal principles have been rejected and then developed and refined as the law continually evolved this relationship that's found between individuals and physicians, hospitals, managed care companies, and others they encounter in the healthcare delivery system. Now, as you noticed when I briefly went over what having a true human right to health means, that generally speaking, individuals really have no legal right to healthcare services or to public health insurance. There really is no general legal duty for healthcare providers to provide care. And this is where this concept of no duty to treat principle comes in. So this principle really came about from a very well-known case of Healh versus Eddingfield. So what was concluded in this case is that obtaining a license to practice medicine doesn't obligate an individual to actually practice or to practice in a particular fashion or with a particular clientele. So the licensure requirement exists instead to filter out individuals who may not have the requisite knowledge or skills to practice medicine. And the truth of the matter, it's very similar to having a law license or a driver's license. The lawyer is not obligated to practice. Someone with a driver's license is not obligated to drive. So it's that kind of idea. Now, even with the passing of the Affordable Care Act in 2010, there was no fundamental right to healthcare services in the U.S. Included in this healthcare policy. But it does push our country in a direction that makes a legal right to healthcare possible down the road. So there's definitely that possibility. All right, so in this slide, we have covering the topic of individual rights and healthcare and looking at it from a global perspective. So the U.S. is one of the only high-income nations that does not guarantee healthcare as a fundamental right. Now, despite being the world leader in terms of development of medical technology and the quantity of medical services, the U.S. is one of the only high-income nations that doesn't guarantee healthcare as a fundamental right. And it's also the only developed nation that has not implemented a system for ensuring at least all but the wealthiest segment of its population against healthcare costs, really controlling them. And about 2/3 of constitutions worldwide address health or healthcare. Now, starting on the next slide, I'll be covering very briefly the 3 primary healthcare rights. And the first one is rights related to receiving services explicitly provided under healthcare, health financing, or health insurance laws. So an example of this would be the examination and treatment for emergency medical conditions and Women in Labor Act, as well as Medicaid and the Affordable Care Act. Now, the second primary healthcare right would be the rights concerning freedom of choice and freedom from government interference when making healthcare decisions, for example, choosing to have an abortion. So here I included that one of the most important healthcare rights is the right for patients to make informed decisions about the scope and course of their own care. And this includes the right to refuse treatment. Now, the third right is the right to be free from unlawful discrimination when accessing or receiving health care. Now, an example of this would be the Federal Civil Rights Act of 1964, as well as the Civil Rights Act for Americans with disabilities. Now, both laws offer evidence of society's willingness to limit physician discretion over patient care undertakings, where the broader goal of non-discrimination is at stake. This legislation actually was considered one of the big milestone achievements by President Lyndon Johnson when he enacted to prohibit discrimination in both places of public accommodation and federally assisted programs and activities. So the basic idea of this act prohibits discrimination on the basis of race, color, or national origin by entities that receive federal funding. Now, the next slide, I will be going over the Emergency Medical Treatment and Labor Act, also known as EMTALA. Now, this act was actually passed in 1986, and it was really a big advancement in social thinking regarding the duties of hospitals and medical staff when treating emergency cases. So under this law, it obligates all Medicare participating hospitals with emergency departments both to screen people who seek care for emergency conditions and to either medically stabilize or appropriately transfer people found to have an emergency medical condition. And also under this law, an appropriate medical screening is one that is non-discriminatory and that adheres to a hospital's established emergency care guidelines. Now, the second duty is to either stabilize any condition that meets the above definition, or in the case of a hospital without the capability to treat the emergency condition, undertake to transfer the patient to another facility in a medically appropriate fashion. And when speaking about the above definition, it's what was stated in the previous slide. Now, the reason behind passing this act is that the truth was that there was a lot of patient dumping that was very common. And this strategy was really found among a lot of private hospitals that were really aiming to shield themselves from the potentially uncompensated costs associated with treating poor or uninsured patients. Now, by refusing to treat these individuals and instead dumping them on public hospitals, private institutions were effectively limiting their patients to those treatment costs, to those whose treatment costs would likely be covered out of pocket by insurers. And the truth of the matter is that the no-duty principle made this type of strategy, dumping of patients, possible. So by passing the EMTALA Act, the EMTALA, or the Emergency Medical Treatment and Labor Act, it was really a conscious effort on the part of elected federal officials to chip away at the no-duty principle by creating legally enforceable rights to emergency hospital care for all individuals. And that meant regardless of their income or health insurance status. Now, there's only a couple of slides left in this PowerPoint presentation, one touching on police powers, and I think there's like 2 or 3, and they're really focusing on the individual rights in a public health context. I am going to wrap this video presentation up. I don't want to get it too long, but I do want to remind you all to take the time to read the chapter. Let me know if you have any questions, and I hope you found this video presentation helpful. All right, everyone, take care. Bye.